Hello, my name is Amaziar Shadman. I'm an associate professor of medical oncology at the University of Washington and Fred Hutch Cancer Center in Seattle, Washington. It's my pleasure to join you at for the IHCH webinar series to talk about bispecific antibodies in lymphoma and discuss this important class of lymphoma drugs that you in Europe have access to, and hopefully we in the United States will soon have access to offer to our patients with different types of lymphoma. And this is a very important time for us as we get access to a number of new drugs, and bispecific antibodies definitely will play an important role in our treatment approach to different forms of B non-Hodgkin lymphoma. So I'm very happy to have the opportunity of having this conversation, and these are my disclosures as a clinician scholar working on different clinical trials using different drugs in the field of lymphoma. We in the lymphoma field are not strangers to T cells and their amazing ability to provide treatment benefit to our patients. Of course, chimeric antigen receptor T cell therapy or CAR T cells are now being used as early as second-line therapy based on some of the recent randomized trials. And we're having more access to CAR T therapy in different types of B-cell malignancies. But CAR T therapy has its own challenges, which is beyond the topic of the conversation today. But very briefly, we know that T cells work and we know that T cells are strong, but CAR T requires a lot of logistics and mainly needing patients to be away from home. The timeline of manufacturing the T cells the way we do them, at least today, could be challenging, and that could limit us in delivering and providing that treatment to the patient. So the idea of engaging the T cells and using their ability to fight lymphoma without having to take them out of patient's body and modify them and waiting weeks for the cells to be made, and if there's a way to still activate the T cells without that process, that would be amazing. Now, bispecific antibodies are designed for that purpose. So basically small molecules that instead of modifying the T cells, they basically bring the T cells to the battlefield and get them very close to the cancer cells, in this case lymphoma cells. And by that proximity of T cells to the lymphoma cells, and by activating the T cells, the normal process of T cell killing happens, and the goal of cell death and tumor death will hopefully happen. And with that, we started a long time ago now, relatively, having access to bispecific T cell engager like Mosunetuzumab, which is approved for the acute lymphoblastic leukemia as this kind of a small molecule that is used as an infusion, and with the concept of kind of targeting CD19 on the leukemia cells and CD3 on the T cells. We've now entered the era of using CD20 and CD3 bispecific antibodies, and there are a number of molecules and drugs in development, and at least one of them approved by the regulatory bodies in the Europe for treatment of for lymphoma. But there are different molecules that could be used, and they have slight differences in their structure, and the studies that are going on or have been done for using these agents have used a slightly different schedules or duration of therapy. But in principle, these molecules are mainly full-length antibodies, and they are basically, they target CD20 in the lymphoma cells and CD3 in the T cells. And we'll go through some of the examples here. What they have in common is that, of course, as drugs, they're off the shelf, and these are not a one-time therapy, which could be a limitation, but it could be also an advantage, because once you have a drug that is done and given, and you don't have much to do to modify it. But in terms of what would be in the case of bispecific antibodies, when these treatments are ongoing and you can redose or change the dose or modify, you have that ability to adjust yourself to, or adjust your treatment strategy to what your patients experience. And I think one of the important points that as investigators, we need to keep in mind is that it's very tempting to have tables and compare molecules that have the same mechanism of action next to each other and look at the numbers. I tried to avoid it, and I did not do it unless, although I did make the table, but I don't want to compare these molecules together because I don't think it's a right way of looking at the clinical data with so much heterogeneity in the designs of these studies. I think the idea should be to look at the general concept to see what is expected from these molecules. And in the next few years, we'll have a lot of data. Who knows, maybe there will be head-to-head randomized trials comparing these drugs together. But I think at the moment, to make any conclusion of efficacy or safety based on small numbers with shorter follow-up would be misleading. And I think I try to avoid this for this talk, and I hope it works. But in general, just a quick summary. This is a very nice paper by Dr. Schuster from the University of Pennsylvania, who summarized some of the features of these these bispecific antibodies, and really listed some of the maybe differences in the structures. These are asymmetrical full-length IgG antibodies, of course, going for CD20 and 3. Of course, the first row here is Mosunetuzumab, which is the BiTE used for ALL. That's not the topic of our discussion today, but drugs like Mosunetuzumab, Glofitamab, Odronextamab, and Odronextamab, I apologize, and Epcoritamab are the ones that are kind of have been used in clinical trials and some approval. And I will try to go through some of the recent or available data very briefly, with a focus of really getting a big picture sense without really trying to compare these molecules together. And the slight or structural differences may not be very clinically relevant. In some cases, maybe in case of Glofitamab, for example, with the unique structure of the 2-to-1 ratio, which I will discuss, that let the investigators use a monoclonal CD20 antibody obinutuzumab in combination. But again, to most part, I'm not sure how the specific structural changes between these molecules would translate to a clinical difference. And again, we need to wait to see the long-term follow-up before making any conclusion. So the next few slides for this presentation, I will walk you through some of the presented/published info or data on the different molecules, and we'll try to get a sense together, and we'll see what we can expect from this class. Mosunetuzumab is a monoclonal antibody. A bispecific antibody, like all other ones that we'll be discussing. It's an asymmetrical. It's an IgG1 full-length humanized antibody for CD20 and for CD3. And what's unique about this molecule is that the investigators actually considered a time-limited therapy in their phase 1/2 study, which has been going on. And I had the pleasure of participating and seeing firsthand some of the amazing clinical responses that this molecule has provided for some of my patients. So initially, a fixed dose schedule was done in group A, but then really the step-up dosing for the cycle 1 and then fixed dosing for cycle 2 and beyond was used. And really the idea of being able to stop treatment in patients who achieved a complete remission or complete response after 8 cycles gave us the opportunity of providing a time-limited therapy. So basically, in the study for most patients, for the group B, for patients who achieved the CR, we would stop the treatment with the option of restarting treatment as needed. And the study included and enrolled patients with both aggressive and indolent histologies. And the idea here is to show you that these were not these were like high-risk patients, but even at the time of this study, which was a while back when CAR T was not necessarily so available and used, but it's still a good percentage of patients with prior CAR T therapy, of course, prior CD20, other chemotherapy drugs, and auto transplant. But really, because practically in these days we an unmet need is the post-CAR T setting. I mean, I'll try to have, of course, also a focus on the post-CAR T data when I discuss these molecules. So, and here you see the 30 patients with a prior CAR T therapy and some of the specifics. So, safety is critical and important. For those of us who use CAR T, and the first thing that comes to mind is like, oh, I'm using an outpatient potentially drug that can also give us cytokine release syndrome and neurotoxicity, and that could be scary, right? So, but I mean, if you look at the any grade or grade 3 cytokine release syndrome, you see that grade 3 CRS is really at for this molecule, for this study. And again, small numbers, remember, a few patients can change the percentage significantly, but we're at a pretty low percentage there. And the use of TOCI is, of course, low because of the lower incidence of CRS. Now, I should mention that pre-medication with corticosteroids for bispecific antibodies, especially in the first few doses, and each drug has its different kind of protocol policy, but that is critical. So we got to remember that pre-medication with the corticosteroids, different drugs are being used, is important in maybe in some of these some of the data that we see with a lower rate of CRS. Same thing with neurological issues that we sometimes expect, and as you see, the numbers are pretty small in percentages, especially for grade 3 or more. Headache and insomnia and dizziness and other related issues are seen. But I think this is an acceptable safety profile, which also comes with a good efficacy. With if you look at the top panel with aggressive lymphomas, a overall response rate of around 35%, with around 20% having a complete remission. And in indolent lymphomas, the numbers are really impressive with 66% overall response and around 50% complete response. And again, I many cases I kind of tried to convince myself not to use cases for this presentation, but from personal experience, many, both for large cell and both follicular lymphoma, extremely high risk patients coming off CAR T with really no other treatment options. They met the criteria from the comorbidity standpoint. As you know, these high-risk patients, sometimes there are challenges to get them on a clinical trial. Fortunately, some of those patients who were able to get the drug, and I have long-term remissions. And it's just an example. I'm sure every investigator has same experience with different types of bispecific. My intention is not to specifically talk about this drug, but I have experience with a few of them, and so these are real drugs and provide real efficacy, and they are well tolerated. And for the post-CAR T setting, again, as an area of interest for most of us, you see efficacy, and I don't want to make much out of 18 patients really for this purpose, but it's bispecifics are very important and a real viable option for the post-CAR T setting as well, something to have in mind when the drug is approved. So the study had expansion cohorts for both follicular lymphoma and large cell lymphoma, and really including patients that are commonly included in studies like this, and with 2 or more prior lines of therapy that included CD20 and alkylating agents. And as I mentioned here, you have the fixed duration therapy, 8 cycles if CR, and if they had less than a CR, they would continue for 17 cycles. There was no need for hospitalization as a mandatory rule, but that was per investigator's discretion to make that decision. And you see the step-up dosing initially and the fixed dosing for the subsequent cycles. And again, really, really impressive response rates and complete remission rates with this molecule, definitely superior to what is expected from our benchmark and historical cohort. And again, this drug is going to be a major player in follicular lymphoma and low-grade lymphomas, in my opinion. And that would be a great problem to have. I mean, as we have a number of other molecules that are under development, and we really need to think seriously about having clinical trials in this space. And the standard of care is, in my opinion, maybe not from the regulatory angle. Maybe some other treatments could be used as a standard of care option, but in practice, when I have a patient in front of me, I have to think really seriously when I am including a patient in a clinical trial that is not using a bispecific antibody, knowing that I have this option. So these are some of the discussions that clinical investigators need to have, and it comes with a lot of ethical points that need to be considered for having and designing clinical trials at this day of age. And same expansion cohort with large cell lymphoma, which used a pretty similar design, and results will be available. Now, what's also interesting and attractive about bispecific antibodies is the ability to combine them with other drugs that are novel, like Plamotamab vedotin is an anti-CD79 antibody drug conjugate. And what if we combine Mosunetuzumab, in this case with Plamotamab, and again, just look at it as an example of being able to combine these novel agents together, and kind of different antigens are targeted, and one drug brings a chemotherapy to the cell, and the other one kind of brings the immune cells, and the idea is to have a better efficacy profile. And in large cell lymphoma here, for example, whether or not patients had prior CAR T exposure or not, you see high response rates in the range of 65% and some complete remission. This strategy of combining with POLA, of course, is being tested in now a randomized trial, and really the next few years we will see a lot of combinations coming, and they will not necessarily be compared to each other head to head, but kind of attention to efficacy and safety of each drug will be critical. And other combinations, and some of these have results that are presented, and some of them are ongoing or planned to be done. And there are many investigator-initiated studies in different institutions which will test even more combinations. So follicular lymphoma, lenalidomide and rituximab, for example, are being Mosunetuzumab in combination with lenalidomide, for example, is being tested against the R-square kind of standard arm. There's a lot of interest in using Mosunetuzumab in the first line setting, and I understand that there is a company-sponsored study, and there was also already a presentation of some initial report of Mosun in the first line setting in the prior ASH meetings. We, in our institution, my colleague, Dr. Lynch, is leading a investigator-initiated study using Mosunetuzumab in the first line setting for follicular lymphoma, with a strategy of adding Plamotamab and Obinutuzumab in patients who don't achieve a complete remission after 8 cycles. So these drugs and this class may change what we're doing. And again, too early to discuss that, but there's a lot of activity in the field. Next molecule is Epcoritamab. Is another CD20 CD3 bispecific antibody. Uses a technology called controlled Fab arm exchange. The idea is to minimize mispairing between heavy and light chains, and to provide a product with high purity. And again, whether or not that translates to a better clinical outcome, it's something we need to see from clinical studies. But again, there's kind of slight differences in the technology and the structure of these molecules. So EPCO is subcutaneous. I should mention that Mosunetuzumab is also while it's intravenous, but the subcutaneous version of it is being tested and used in the studies, and will and may be available as well. But EPCO was from the beginning a subcutaneous drug, and the schedule that you see here for weekly for the first 3 cycles, and then every 2 weeks for cycles 4 to 9, and then every 4 weeks. And the study that I'm showing here is the more recent presentation from the European Hematology Association meeting in 2022. And, the kind of patients with large cell lymphoma, and the baseline characteristics are listed there, not reading all of them, but kind of median time from initial diagnosis to dose was pretty short, and median prior lines of therapy of 3. 40% of patients had prior CAR T therapy, and from that 61 patients, 46 of them, or 75% of them, had progression within 6 months of CAR T therapy. And we all know these are super high risk patients. Again, safety profile is something that is, again, at the very low percentage at grade 3, 2.5. And, it should be noted that most of these happen early on with the first full dose, for example, here, and predictable and reversible. And, we will talk about it, but it's important. These drugs have the potential and will be used in the community setting in centers that are not necessarily academic or large volume where we use CAR T therapy. So, things that, may look, the percentages that may look small for those of us who practice in larger centers could be significant in a smaller setting. Remember that, for example, in the US, in some settings, you don't necessarily have access to experienced personnel who are used to be treating cytokine release syndrome or neurological toxicity. So yes, 2.5% is a small number. 4 patients is not a large number, but I mean, if your patient is that one patient, it is significant. So again, I emphasize on the fact that prophylactic corticosteroids are important, which they also come with their own risk. We are now seeing patients who have side effects from corticosteroids, but again, we are all used to managing side effects, and I'm sure it's doable and usable, but kind of attention to the first few doses in terms of CRS, and having a hospital setting that is prepared and aware of the potential patients who are, for example, receiving bispecific antibodies is important. Now, its response rate with in this study was very high and impressive in the 63% range with 40% complete response. This is really, for a monotherapy, non-chemotherapy drug and antibodies, is an impressive number, I have to say, in such a high-risk population that you saw. And interestingly, in different, when you look at all patients, you have that response rate. Each bar shows you the response rate, and green is complete response and PR is partial response. And but then you look at different ages, you look at different histologies, different types of large cell type histology, for example, de novo, transformed, and also primary refractory. More importantly, if you look at the CAR T exposed and CAR T refractory, just visually the bars may have different height here, but in general, I think it's an acceptable and pretty effective drug in that setting, I should say. And prior lines of therapy did not appear to change the response rate. And as expected, in patients who achieved a complete response and followed by PRs, they had durable responses. So it's important to see that these drugs, it's important to have that initial response, and it's great, but what matters for patients and for us is that durability of responses, and sounds like that's achievable by these drugs. And then combinations like other drugs that I mentioned, like for example with our Revlimid, rituximab, and lenalidomide, or R-square with chemotherapy backbones. Epco has been tested and combined, and it's feasible and effective. And again, we will have a number of combinations that will be done in the studies and phase 2 single arm or randomized studies. And, again, there may or may not change our practice. I think the take home point is that you can use these drugs and combine them with everything else, either chemo or novel agents. And I think that's a very important feature. Odronextamab is another bispecific antibody, again for CD3 and CD3 and CD20, and study. Again, these designs are pretty similar. I'm not going to look at it again. Here, I'm not going to repeat it again here, but just pay attention to the lower part that, that split dosing or step up dosing, that's a common feature for most of these studies that I'm showing. For here, for example, in cycle 1, patients got treatment on day 1 and 2, and then 8 and 9, and then 15 and 16. Dexamethasone pre-medication was also important part of the first the split infusion and maybe the second one, so that's something to remember. But again, the structure here is that 1-to-1 ratio, asymmetric full-length IgG bispecific, similar to the other drugs. Here we have the same kind of pattern against the CR grade 3 or more CRS of less than 10%. You know, the number may be a little bit higher, but as I said, these are small number studies. I would encourage myself always not to try to make comparison, but I think we get a sense. These are feasible drugs to give in the community and to less experienced and smaller community settings. There is no new safety or unexpected safety signal with this drug either, and you know, just highlighting the AEs of interest, as we call them. And but the responses were again high with this is the follicular lymphoma cohort. You look at all doses and then more than 5 milligram dose that they used, and you know, very high response rate in the range of 80 to 90% with a CR rate of 60 to 70%. Again, small numbers, but a very effective drug, no question about that. And the large cell lymphoma, looking first at patients with no prior CAR T experience, and here you're at the again, all doses and more than 80 are reported, and again, somewhere between 40 to 50% response and 25 to 50% complete response rate, depending on the dose. And for the post-CAR T setting, you have that CR rate of 25-ish%, and response rates overall are seen in 1/3 of patients. So again, continuing that theme of these are effective drugs, could be used in the post-CAR T setting, and responses could be durable. Here you have separation by histology, not the type of response, and you have the follicular lymphoma in the blue color curve, and I believe it's black or maybe navy, and then green for no prior CAR T and prior CAR T respectively. And the ELM-2 study, which is a follow-up study, is also looking at different histologies other than large cell lymphoma, including large cell, but also other histologies. And we don't have results of that yet, which will I hope be available at some point. Now, moving on to Glofitamab, it's another CD20, CD3. This one is a little bit different in structure if you pay attention to the right side. Unlike other molecules, this is the CD20 arm is longer, and there's this 2-to-1 configuration that, you know, there's more there's while the CD3 remains monovalent, there is bivalent CD20 arm, which in the opinion of investigators give you that advantage, competitive advantage for this antibody to be given with another CD20 antibody, in this case Obinutuzumab. So because there's a more affinity to CD20 antibody here, it's believed that the potency is reserved or preserved in the presence of either another CD20 antibody. So again, important points to know, but again, in my opinion, the clinical endpoints are probably the critical variables and facts for us to believe it's whether or not dosing that you see here in the figure for cycle 1, and then beyond that, the fixed dosing. High response rates for aggressive lymphoma, again, 80% and 60%. This study also included patients with high-risk disease, and responses were seen in different categories regardless of that. And durable responses, again, in patients who achieved an overall or complete response, responses could be durable. In indolent lymphoma is the same pattern, whether or not the drug was given with obinutuzumab or not, you see, and the different dose levels, response rates are seen, and really focusing on the right side on some areas of interest. For example, the second group of columns are the POD24. These are patients who have progressive disease within the 24 months of finishing induction therapy for follicular lymphoma, for example. And you see that in patients who, in blue, patients who received Glofi as monotherapy, or in orange, patients who received it with obinutuzumab, high response rates and even CR rates. Again, important gaps that we're trying to fill with these drugs. I mentioned the post-CAR T setting. Here we have the POD24. And in different diseases, like in mantle cell lymphoma, you have this post-BTKI setting. Of course, we have CAR T. Right now, we have Bruxocel approved here in US for treatment of high-risk patients with mantle cell lymphoma, an effective treatment, but toxicity is a major challenge for CAR T like Bruxocel. So if there is a way to either find another strategy that's as effective and could replace CAR T, or maybe you can debulk these patients before sending them to CAR T. One of the challenges we have specifically for mantle cell lymphoma is having patients controlling their disease while we have them on the service to get them ready for CAR T. This is one of the most difficult histologies to deal with in the pre-CAR setting. And there's a lot of discussion could be made on what's the right time for referral in patients with mantle cell lymphoma, so you don't have to deal with that situation. You should be getting the patient when they have a stable disease, and you don't have to worry about providing or giving high dose cytarabine, for example, in a few weeks before your CAR T. So the point is having a drug that's effective, and again, in the post-CAR T, post-BTKI setting, for example, there is a big unmet need for mantle cell lymphoma. So it's good to see that there is also activity in mantle cell lymphoma. I believe these are too early and relatively small size studies to make strong conclusions about, but I think another area that the bispecific antibodies could really play an important role. I just give a few, like I have a couple of slides on Plamotamab. That's another bispecific antibody, again, CD20, CD3. Again, you see that step up or different terminologies that are used for that dosing schedule for the first few doses. And, same principle, responses are seen, large cell lymphoma, follicular lymphoma, very small numbers here. So there's no way that having a site-to-site comparison makes sense. But I wanted to say, just use this as an example of, combinations are feasible. For example, this molecule is being tested in combination with tafasitamab, which is an anti-CD19 naked antibody, and lenalidomide. So the field will explode by having a number of studies that use different combinations. So again, I just wanted to use this as an example of another combination study. So bispecific antibodies, T-cell engagers are important, and they will be available, and they will be a major player in treatment of B-cell lymphomas. They could be part of our first, second, and third line in combination with chemotherapy or novel drug backbones. They could be used as monotherapy depending on the setting that we're using them. They have efficacy in patients in relapse disease. They have efficacy in patients who are defined as having high-risk condition these days. They're feasible to be given in the community. So the access problem that we have with CAR T is going to go away to a large degree, and that's extremely important. Unfortunately, all the data we see for CAR T is just looking at patients who made it to CAR T. So, and we can study, and we are actively studying to see, okay, which patients can't make it and what are the reasons, but it's difficult to study it. We can start from the point that patients are referred and see why they didn't make it to CAR T, but there are many patients who are not even referred. There are patients who have the conversation with the primary oncologist. The physician never makes a referral because they decide, and they're right, that this patient doesn't have the means of having access. So that problem will go away to a large degree when we use bispecifics. The adverse events of interest, like cytokine release syndrome, neurotoxicity, can happen at much lower rate, and they happen early. So that gives you that predictability of being prepared and kind of working with your team to be able to manage those side effects. And as I mentioned, these drugs are effective in different settings that are high risk, so post-CAR T, post-stem cell transplant. These drugs, although they're also CD20 targeting, they work nicely in patients who had CD20 monoclonal antibodies like rituximab or obinutuzumab, and those drugs failed them. So you can expect effectiveness, and of course, after chemotherapy and targeted drugs. And these are real drugs. They give you complete remission. They give you durable remission. And more importantly, and I repeat again, they can be combined with novel agents, antibodies or CAR T. There's no head-to-head trials. We can't answer that question. Will there ever be a randomized trial? Maybe, maybe not. To answer that question, we need an intent to treat study to look at patients who are intended to get CAR versus bispecific. It wouldn't be right to look at patients who receive CAR versus those who receive bispecific. But, in the absence of such randomized trial, we have a patient in front of us and we think about variables that I've listed here. For example, bispecifics are available when they're approved. They're available. They're off-the-shelf drugs. You can start treatment very soon. It's feasible to be done in most of the community oncology practices. The time to response is relatively short after a few cycles. Adverse events like cytokine release syndrome and neurotoxicity are less common and are more predictable. They usually happen early on. And most importantly, these drugs can be combined with the novel agents, as we saw with chemotherapy or novel agent backbones. Now, cons, treatment duration is long. They're either indefinite or relatively long, with the exception of at least Mosun, that is 8 cycles, but that's still 8 cycles. That in cycle is 21 days, so you're looking at 24 weeks. And that requires frequent visits, anywhere between once a week to every 4 weeks. And the follow-up remains to be short relatively for bispecifics at the time. CAR T, on the other hand, is a one-time treatment. And if it works, and there is a good chance that patients remain in remission for a long time, and that's really valuable for patients not to receive treatment and not to have a disease. The adverse events are acceptable, especially with the 4-1BB co-stim CARs, and with the CD20 co-stim CAR like Axicel or Bruxicel, with the prophylactic strategies, the side effects are even the side effects for CD28 CARs is becoming more manageable. You can combine with CAR T with novel agents, probably not as good as bispecifics. There are, of course, BTK inhibitors and other agents that are being combined. But it's probably more limited than what we can do with bispecifics. The follow-up is much longer and the data is solid with CAR T. We still have to work on the bispecific data and wait for more follow-up. But the con is you need to you need to refer the patient to another center. And at least where I practice, we have many patients. Most of our patients come from different cities and states. They have to stay in Seattle for a couple of months, stay in a hotel setting, and having a caregiver and being away from home and family. It is important, and it could be a major barrier. So that would be some disadvantage that, if you can list for CAR T. But potentially these two can be combined. I don't think we have to pick a winner. You can have a strategy that you use CAR T first and go with bispecific antibody as a maintenance or consolidation, or vice versa. Maybe start with bispecific. If you see the response, great. If you don't, or if you have a feeling that you're not achieving that CR or your patient's disease is back, then make a referral to CAR T. I think it's a matter of sequencing and not picking the winner. But again, I think it's great times for us investigators and physicians to have access to so many great drugs that can benefit our patients. And I hope that we'll learn enough and work more to have reasonable and effective options for patients and find the right match for each patient in terms of what efficacy and safety and also feasibility for every single patient that we have. Thank you very much for your attention, and I appreciate the invitation again.